We're super excited to be spending this last month on the theme of decolonizing COVID. We have explored multiple themes under this overarching programming umbrella, and we think the time is right to end this 6-month-long series on this very important theme. So I'm going to just get started. I see people are coming in, but that's fine. A couple words on the format for today. If I could just ask those of you who are just coming in to put your microphone on mute. There will be plenty of time for question and answer, so you're welcome to unmute yourself at that point. You're welcome at any point during the talk to pop a question in the chat, right? As things come to you, as you have thoughts and questions, just pop it in the chat. But also at the end of, after 30 or 40 minutes, you'll have an opportunity, if you so wish, to ask your question live or put it in the chat as you wish. So my name is Dr. Elizabeth Kolsky. I am the director of the Albert Lepage Center for History and the Public Interest, and I'm also an associate professor of history at Villanova University. And I'm very excited to moderate this conversation with our speaker for today, who is Graham Mooney. I'll do a quick introduction, and then the plan is to have a kind of informal conversation that will last 30 to 40 minutes, followed by audience participation. Right? Any center doing history in the public interest relies on the public to engage with us. So we really hope that you will, right? If there's any topic that is relevant, historical topic relevant to your lives today, it is this topic. So let me just quickly introduce Professor Mooney. Professor Mooney is associate professor in the Department of the History of Medicine and the School of Medicine and Department of Epidemiology in the Bloomberg School of Public Health at Johns Hopkins University. His work focuses on the history of public health in modern Europe and North America. His 2015 book titled Intrusive Interventions, Public Health, Domestic Space, and Infectious Disease Surveillance in England, 1840 to 1914, examines the history of public health interventions such as infectious disease notification, institutional and domestic isolation, disinfection, and contact tracing. All concepts that probably a year ago would have sounded very unfamiliar, but now sound so painfully familiar. So his present book project, which is titled Harm City, Health and Injustice in Urban America, is a case study of class and race politics in Baltimore that explores the neoliberal fracturing of public health systems and policy in American cities. So I am very grateful to be here today with Professor Mooney. I also want to thank my colleague, Professor Paul Steggy from the Department of History, who's worked with me to put together this whole month of really exciting events, and I hope you'll stay with us. So I just want to get started with my classic softball question, which is to ask Professor Mooney, how did you become a historian of medicine? You have to unmute yourself.
I behave myself and unmuted, and then I forget to unmute, and I forgot to unmute. Okay, well, that's an interesting question of itself. It's not such a softball one for me either. I just want to make a couple of acknowledgements before we get going today. First of all, I want to acknowledge that I'm standing on the stolen ancestral land of the Piscataway people in Baltimore City. I want to acknowledge that point. I also want to acknowledge that it may seem, in fact it is somewhat ironic, that in a discussion around decolonizing history, a white cis guy from a very powerful and well-resourced institution is talking to you here. I think I came to the attention of you folks through an article that I co-authored with colleagues of mine that got published in The Lancet, which we may have the chance to discuss a little bit later on, which was about racism in the history of medicine. And my co-authors, Aya Nuruddin and Sasha White, were also invited to talk to you today, but for various reasons. Aya is dissertating, she's hopefully defending next month, and Sasha is teaching. They couldn't make it, so I just want to acknowledge their labour and the labour that they put into that. Also, the fact that send their apologies that they couldn't participate today. So I'm, with their agreement, I'm representing them today. How did I become a historian of medicine? Well, originally I'm a geographer. I'm a trained. I did an undergraduate and graduate degree in geography, I became interested in historical geography, particularly geographies of health and inequality. And after doing a PhD on the history of epidemics and mortality in Victorian London, I went and worked in public health for a bit, came back and actually worked in a history department, then got a job in a geography department, and then came to Hopkins in the history of medicine because I wanted to use my teaching in public health context as well as history context. So it's a rather convoluted way in which I got it. But my window into history was through health and health inequalities and trying to explain the deep roots of spatial inequalities initially, because I'm a geographer, but then also other kinds of inequalities as my work has developed over the years.
Very interesting. So speaking of inequality, right, there's been a lot of conversation about racial and health inequities that have been spotlighted by COVID on the one hand, and on the other hand, there's been a lot of denial of same. So the most recent example of this is a podcast and a tweet from the Journal of the American Medical Association, in which it was claimed that, quote, "No physician is racist, so how can there be structural racism in healthcare?" And indeed, for many people who associate healthcare with healing, it's like it's hard for them to wrap their head around doctors being something other than healers. But there was widespread outrage that was expressed on social media and in the mainstream media. The journal editors who were involved in this podcast and tweet were resigned or placed on administrative leave. So I'm just wondering if you can help our audience understand what is structural racism, what role it plays in the history of medicine, and why there was this recent outcry, which is, I think, happened within the past week or so.
Yes, it's been over the last couple of weeks and it's still ongoing. And I know that the American Medical Association and the Journal of the American Medical Association are having an internal investigation into how this podcast happened and the outfall from it. So yeah, it's an ongoing thing. I just want to step back a little bit from structural racism to think about what is also termed structural violence, because structural racism is part of a bigger concept which has been termed structural violence, which had its origins in the 1960s in peace studies as a way of understanding the impacts of imperialism and colonialism that persisted in the post-colonial world, the kind of violences that were enacted upon colonized peoples, that then that violence persisted in its after effects, continued to be observed. And so the history of medicine and public health in the US is marked by all kinds of forms of injustice and what we would term violence. So I don't just mean physical violence. There's ideas of mental and mental trauma, psychological trauma, and so on. And we might think of something like unequal access to medical care as a form of violence enacted upon people who have trouble accessing medical care. The segregation of medical facilities, which was very common until the mid-20th century. The exclusion of African Americans from medical education for so long. My own institution, Johns Hopkins, didn't graduate a black physician until the mid-1960s, for example. And so these are some of the most obvious examples. And when you put these together with inequities in housing, in residential segregation, in employment and educational opportunities, and the massive wealth gap that we observe between white folks and then people of color, black folks, indigenous people, then we can call that systemic racism and structural racism. It's embedded and baked into the very structures through which we live our lives. And just to give a few examples of the way in which we can think of this, the AMA itself, the American Medical Association itself, its own founder, Nathan Davis, excluded black folks from participation in the American Medical Association. And again, it wasn't until the 1960s that exclusion was removed. And in the meantime, African American physicians had set up their own journal and their own outlets for discussion about medical issues. Benjamin Rush, you know, fairly well-known figure in the history of the United States, opposed slavery, but he was also complicit in a kind of anti-blackness around his experiences with yellow fever, and you know, the idea that African American bodies are more resistant to yellow fever. Also, the idea that black bodies were able to withstand pain in ways that white bodies weren't. And this is very much anti-black opinion and ideas formed through ideas that were taken from slavery. So there are all different ways in which structural racism plays its way into health and medicine. Another one would be eugenics. Many physicians, end of the 19th, early 20th century, and one would hesitate to say, but possibly into the present, had eugenic ideas and participated in eugenic organizations that we still see the ramifications of in healthcare today. Ideas about genetic differences between black people and white people, and the way in which that feeds into notions of disease susceptibility, for example. So there are a bunch of ways in which structural racism can be observed through medicine and health.
I'm wondering if you can give some examples of what is the impact of past and present racism on health outcomes, and how have these been highlighted, illuminated, made visible by the COVID-19 pandemic?
Yeah, well, let's think about infectious disease. Let's take COVID as an infectious disease and think backwards with that, or work backwards with that. So the work of, I'm going to draw here on the work of historian Jim Downs, who has written about the Civil War and the process of emancipation. And he argues that emancipation unleashed a kind of biological penalty on the vast majority of formerly enslaved people who became displaced. They lacked basic necessities, and they were deprived of access to medical care. And these are all forms of structural violence that we discussed in the previous question that you asked, that reproduced the experiences of slavery in a nominally free population. And so formerly enslaved people were disproportionately exposed to the ravages of infectious diseases, smallpox, yellow fever, cholera, for example. And the excess mortality and morbidity of black people was therefore a direct consequence of emancipation that brought into question the very idea that they were free. And I'll try and talk about notions of freedom later on. And this persists into the present. So you still have disparities in infant mortality rates between whites and blacks. So, for example, at the turn of the 20th century, the difference was double. The infant mortality rate for whites was around about 100 infant deaths for every 1,000 live births. For blacks, it was 200 infant deaths for every 1,000 live births. Now, the infant mortality rate is closer to 6 infant deaths per 1,000 live births. But the disparity is exactly the same. It's still 2 to 1, still double in the black population compared to the whites. In Philadelphia, black men have a life expectancy that is the lowest of any major, which is the lowest of any major demographic group. It's less than 70 years life expectancy for black men. So these are some of the ways in which the long-term effects of structural racism in health and disease become reproduced and continue into the present. And that's even before we get onto access to healthcare and so on.
So if I can just follow up, so how has COVID-19 made these long-standing inequities more visible? Because what you're pointing out is this is new. It's 2021, right? You're talking about the Civil War. That's 150 years ago. So how has COVID-19 amplified this visibility of this long-standing issue?
So even quite early on in the pandemic, going back to April, a year ago, April, May 2020, when, well, first of all, I will say that initially, for example, in Maryland, they weren't even disaggregating testing and mortality and morbidity by race. They didn't even think of doing that immediately. But people understood and realized that if you know anything about health and healthcare, historically or in the present, there's going to be racial differences in particular are going to be manifest in a pandemic. So early reports, when the analysis began to emerge around about this time last year, showed that in almost every single setting, African Americans were contracting the virus at much greater rates compared to other groups, but particularly whites. Latinx people also had higher rates. So I'm just reading off a couple of examples that were being observed in this time last year. In Milwaukee County, African Americans accounted for 27% of the population, but over half of all COVID-19 cases. Illinois, 15% of the population, 33% of COVID-19 cases. The figures are basically the same for everywhere you look. It was similar here in Baltimore as well. And the point about this is that it's not just about access to healthcare, although it is about access to healthcare and the way in which people were able to manage their underlying conditions pre-pandemic, such as hypertension, say. But it's also about the fact that African Americans, Latinx folks, indigenous peoples, they're overrepresented in the kinds of occupations that were seen as being, they got termed essential workers, but that was something that was very much in the discussion a year ago. But they were on the front line of the pandemic, working in healthcare settings, education settings, and so on. And so that also means that quite often, because they're working in these low-paid, low-status occupations, they're, for example, dependent upon public transport for getting around, and that gave them further exposure to the virus. And so because healthcare and access to healthcare quite often is related to and associated with employment, it's usually least accessible to those who need it the most. So it wasn't surprising that when you have an infectious disease that is spread as easily as COVID-19 spread, you're going to get these differences showing up.
Interesting. So you mentioned earlier, I mean, I find it there's an interesting contrast between, on the one hand, the Journal of the American Medical Association denying that structural racism exists, and the article that you mentioned that you had co-authored with your colleagues at Hopkins in The Lancet, which is, correct me if I'm wrong, a British medical journal, correct?
It is, yeah.
Okay. So, and you published this really interesting article co-authored with your colleagues titled Reckoning with Histories of Medical Racism and Violence in the US. So I'm wondering if you can talk to us a little bit about that article and if you see parallels or what kind of parallels you were drawing in that article between the past and what has happened, right? Because the time that article is obviously very timely, right? It's no coincidence you're publishing this in October 2020. So what kind of parallels were you drawing in that piece? And how might you explain why the Lancet is out front with this and the Journal of American Medicine is kind of denying it? I mean, I don't know what you make of that. Yeah.
Well, there are some interesting, there's some interesting, we could have an interesting discussion about that, about the difference between the sorts of journals and the broader response from the scientific journal community to the podcast. I think one of the things that we wanted to do, and this gets back to what I was saying earlier about structural violence, there was a moment, where these racial and ethnic disparities in COVID morbidity and mortality were beginning to be studied and emerged. And then you had the Black Lives Matter movement and the protests over the summer. And we were seeing links between, what we think of as structural violence, all this is tied together. The ways in which racial residential segregation, hyper-policing and monitoring and surveillance, and public health outcomes. So, we wanted to draw attention to the fact that these forms of structural violence have very long roots and they persist into the present. And if we can think about medicine not as this sort of siloed practice, but something that is connected in a multifactorial way to lots of other things that are going on in our society, then we can begin to confront the racism that exists within medicine itself. So we draw on a bunch of specific examples to try and highlight this. So one would be, some of you may have recalled from a few years ago the taking down of the statue of James Marion Sims in New York, arguably a doctor otherwise known as the father of modern gynecology, but he came to lots of his discoveries through experimentation on enslaved women, and he also forced them into performing domestic duties and serving nurses in his clinic. So there are multiple forms of structural violence going on there. And so enslaved women were used in the early iterations of gynecology as a specialty in ways that you wouldn't observe for other populations. So slavery is intimately connected to the development of modern medicine. And yet so there's an image, there's an idea there. And in the words of, I'm going to read the words of Dr. Deirdre Cooper Owens, who has written a book about the origins of modern gynecology. To early gynecologists, the bodies of enslaved Black women were flesh and blood contradictions. They were vital to their research, yet dispensable once their bodies and labour were no longer required. And within reproductive rights, which I think is a really good example of a good example to follow through historically, Native American, African American, and Puerto Rican women were overwhelmingly targeted for involuntary sterilizations and compulsory sterilizations under early 20th century eugenic laws. So that's one example of the ways in which one of the examples we wanted to draw attention to around the roles of structural racism and medical practice. Another might be the ways in which public health responded to plague outbreaks in the early 20th century. There's a very good example example there, in the sense that the Chinese Exclusion Act from 1882 was very much related to fears about the spread of disease and the othering of the Chinese population through disease and illness. And it was manifested when there was a bubonic plague outbreak in 1900 that threatened San Francisco, and the public health authorities established a blanket quarantine over the city's Chinatown, not letting Chinese folk move in and out of the quarantine, but not to the white. There was no equivalent quarantine to the white population, and they roped off certain blocks. Only whites were allowed to leave the quarantined area, and so on. And that kind of helps us understand the sorts of tropes that were being wheeled out at the beginning of the pandemic around the China virus and so on. It also helps us understand some of the responses to the recent shootings in Atlanta, and the long-held discrimination and prejudices that have been exhibited towards Asian Americans. So there are a bunch of ways in which we think these things are connected, and why we decided to sort of try and draw attention to them in the middle of last year.
And of course, that also links to the question of empire. I mean, it's my understanding that the history of infectious disease is tied to the history of what was once called tropical medicine. It's no longer called that anymore, correct? Which is itself a kind of field in the history of medicine founded in connection with the history of empire. So it's not only about slavery. So did any thoughts about those connections?
Well, I think there's been a recent revisiting of the sort of colonial and post-colonial medical complex, let's call it. But definitely, historians of medicine have spent a long time exploring the ways in which medicine and public health were used as, to put it crudely, tools of empire. The ways in which the, public health legislation, the ways in which medical practice, in hospitals, through missionaries, public health activities like the ones that I'm interested in, disinfection, isolation, so on, were used as ways of inculcating certain forms of norms, behaviours, and activities that surveilled and managed the colonized population. So yeah, absolutely, it totally, there's a very close link between medicine and colonialism.
No, I'm glad you bring up your work, because I did want to talk about your work on what I believe you call, or I'm not sure if you're quoting someone else, infectious disease surveillance. All right, this is a concept that's central to your 2015 book, in which you talk about compulsory infectious disease notification, which has me thinking about all the debates that are going on right now about these, in opposition to the vaccine passport and the denial of freedom. It's a whole thing, which we can get to. You talk about domestic quarantine, mandatory hospitalization, disinfection of homes and belongings. And a lot of these really resonate with the world that we live in today. So I'm wondering, how do past efforts to implement these public health interventions help us understand present efforts, right? To what extent in the past were people mobilized and consenting, right? Consenting to these types of interventions, and to what extent were governments in the past enforcing coercively these types of interventions to ensure the slower stop of the spread of various infectious diseases?
Yeah, I think the way in which we can, connect the two, the historical and the contemporary, or one way at least, is to think. I do it through thinking about, one of the ways is through thinking about freedom and what freedom means in different historical contexts. So, many of the people who object to the kinds of things you just mentioned, quarantines, isolation of contacts, quarantine of contacts, isolation of people who are sick, closing of businesses, mask wearing. They see it as infringement of their liberties. Okay, it's their infringement of their individual right to do what they want and make their own choices about health risks. And when we think about the Victorian Britain period, it wasn't just one disease that they're kind of focusing on. There was a whole range of, we've already mentioned some of them, but smallpox, cholera, diphtheria, typhus, measles, scarlet fever. All these had death rates that, they wouldn't be seen as big or huge compared to, say, tuberculosis was in the past, but they presented major problems for public health administrations, which themselves were relatively new things on the government landscape in the mid-19th century. The idea that we should organise government to prevent illness and infectious disease didn't really cement itself until the middle of the 19th century. And so these were killing lots of people. So what public health leaders did then was they actually put together an argument about freedom. But the freedom was the freedom from disease. How do we get ourselves free from disease so that we can be free in other ways, so that we can enjoy walking about the streets without worrying about passing on an infection to somebody else, go to work, use public transport. So the idea was that citizens have the right to be free from disease. If we're going to ask citizens to do things like pay taxes, if we're going to ask them to enroll in the military, if we're going to ask them to produce goods through which our nation's wealth is enhanced, then they have certain rights, and one of those rights might be to be free from disease. And to protect this right, the government should have the ability to intervene in their lives. Quarantine those who are sick, vaccinate people to stop them from being sick, and take other steps to reduce the threat of infectious disease. So I think if we want to do that, if you want to think about the connections, freedom and notions of freedom is one of the ways that we can do that. And to say to people, yeah, okay, so individual rights are very important to you, we understand that, but you really have to understand that, you know, it's without doubt you're endangering the freedoms of other people. So, you know, if you're okay with that, that's up to you, but, you know, we need to find a balance between rights and, you know, duties and rights and responsibilities. And I think that's where, you know, it's fundamental. Public health is fundamental to our notions of what it means to be a citizen historically and in the present. Is how far are we able to articulate rights and responsibilities as citizens through public health. So public health is a really good way of thinking about how we constitute ourselves as members of a polity and as citizens that have connections to other human beings around us.
I'm wondering if, in terms of this balance between persuasion, right, persuading people to, in today's terms, mask up, social distance, the balance between persuasion and coercion in terms of government efforts, how this broke down along the lines of race and inequality. For example, I'm a historian of India, and there's a very famous case I'm sure you're aware of involving the Contagious Disease Act passed by the colonial government in 1864. And this act attempted to control the spread of venereal disease. But the way it did this was by creating what were literally called block hospitals, in which Indian prostitutes were locked up until they were seen to be free and clean of disease. But of course, the soldiers who were having intercourse with them were not ever locked up. So again, the coercion fell more, the coercive effort of the state fell upon the bodies of Indian women who would be, the doubly different, as I've called in my own work, right? They're women, yeah. They're Indian, they're gendered, racialized bodies. So I'm wondering if there's other examples in the United States, for example, where we see this same type of, right, coercive efforts of the state falling harder on, on oppressed people.
Yeah, good point. Yeah, that double standard of the Contagious Diseases Act is a really interesting example. And in fact, just as an aside, our modern forms of contact tracing that we're now all familiar with, they were really shaped in like the interwar World War II period for syphilis and venereal disease. They were very much, what we now know of as contact tracing was something that happened previously, but they were really, the forms of that were definitely shaped around syphilis and venereal disease. I think one good example of this that I'm very well aware of is it's something called they were called lung blocks. Okay, there were places in cities that had high rates of tuberculosis mortality, right? And in New York had one, Baltimore had one, St. Louis had one, Chicago had one, and I'm sure Philadelphia probably had one as well. These were places that had high mortality, but they also tended to be places where certain kinds of people lived. So in Baltimore, it was Black folks, African Americans. In New York, it was the Jewish population. In Chicago, it was very much centered on where the common lodging houses were. So they were really worried about people, vagrants spreading disease. So it's kind of like the lung blocks were sort of like this plastic notion that that we need to focus on a particular area of the city, and we'll use disease as the justification to do it. Because in Baltimore, the lung block, which was mostly African American folks, there were also other places of the city that had high levels of tuberculosis morbidity and mortality. They just didn't happen to be a focus and concentration of Black folks in an environmentally degraded area with very poor housing and so on. So they become used. Disease and space become used together to demonize a particular group. And in the case of the Baltimore's lung block, it was African Americans. So that's just one example of how public health was explicitly racist in terms of its policies to focus on that particular area. And so it became an area where there was lots of agitation for housing reform and so on. But it was also an area where people were, it was to do with the behaviors and the morals of the people who lived there, rather than the environment and the neglect of the authorities, landlords, and so on.
So I mean, I think these examples that you give us helps us understand that some populations have historical reasons to be skeptical of government efforts. And we've seen a lot of the government kind of messaging has been targeting Black Americans in terms of encouraging Black Americans to get vaccinated. And over the weekend, there was a skit on Saturday Night Live. I don't know if you saw it, called, oh, you didn't see it?
Not yet, no.
Okay. It was a parody of this problem that Black Americans don't want to get vaccinated, and it was called "Will You Take It?" And many people didn't find it very funny, particularly many kind of prominent, outspoken Black doctors who kind of criticized the skit for failing to contextualize and historicize why are Black Americans skeptical about taking the vaccine, right? And explaining, sort of the history of racism in sort of public health interventions. So I'm just, and then on the other hand, of course, we also, I recently heard on NPR that 41% of Republicans are also skeptical and refusing to take the vaccine. Many of them, it sounds like, for reasons related to freedom and liberty. Yeah. So I'm wondering, how do we deal with, in this kind of era of this sort of deadly pandemic, these varying strands of skepticism around government efforts to eradicate the disease?
Good question. And I think, to also add another bit of data to that, I think there was an NPR survey last month, a few weeks ago now, that basically showed that the willingness to be vaccinated, there was no difference between the black and white Americans. They were, it was in the mid 70% of people. So first of all, we need to dispel that myth. To begin with, and it is contextual and contingent on what the disease is, what the intervention is, and where we are. So there's that kind of thing. Then also, history is important in this context because I think a lot of people think of vaccination, anti-vaxxers, for example, as it's all to do with the debates around the MMR immunization and its links to autism in the late 90s and early 2000s, which is a study, incidentally, that obviously has been debunked. It goes much further than that, back to the first vaccine that was available for smallpox, where people resisted, and they were known as anti-vaccinationists. They resisted vaccines because they were a compulsory measure. So this goes back to lots of countries made it law to vaccinate your children. So it was interference from the state, interference with freedoms. Some people thought that, for religious reasons, faith-based reasons, this was medicine interfering with the will of God, and being ill was a divine intervention that you shouldn't mess around with. There was an exchange of bodily fluids with vaccination early on. Quite often it was done what was called arm-to-arm vaccination. So you'd take the fluid from the pustule of one person who'd been vaccinated. They had pustules on their arm, and you would draw it off, and then you would use that to vaccinate somebody else. Don't know about you, but that sounds not something you would willingly do unless you really thought, okay, well, is it worse if I die from smallpox? Also, some people object to the fact that they used cows and horses were used to produce the vaccine. So there were religious reasons to that. But this has been in a sick cow or a sick calf. Who wants to take that? So they're the context and the contingencies around the history of anti-vaccination. When you put race into that, we're thinking about the distrust, particularly of the medical establishment, through some of the examples I've shown. The more popularly known one of the Tuskegee syphilis experiment. There is a level of distrust, but as the sociologist Rua Benjamin has argued, we need to think about informed refusal, which is a bit like, it's a corollary to informed consent, in the sense that Black people refuse to enroll in research studies and clinical trials because they've been historically exploited and marginalized and disempowered. And so what really needs to happen is that institutions have to work harder to gain their trust, not just marginalize folks from access to healthcare and then turn around and say, oh, we've got a vaccine here, why aren't you coming to use it? Well, we've been used to being excluded from all this, and for racist reasons. Why should all of a sudden we turn around and take the vaccine, when really institutions need to do way more work on rebuilding the their own institutional expectations that takes structural racism and structural violence into account.
This is just super fascinating. I promised that we would talk for 30 to 40 minutes, and my clock tells me that my 40 minutes have expired. So I see some excellent questions in the chat. I encourage anybody to raise your hand if you want to, express a question verbally, or if you want to post it in the chat. I'm happy to field questions that way as well. But these last 20 minutes are really for all of you to ask Professor Mooney sort of questions that pertain to what he's talked about today, or more broadly, questions that pertain to the history of public health as it relates to this present moment. So one question I see here from Janet Frazier, which is an interesting one, is what kind of racial patterns do you see among past epidemics? For example, smallpox, yellow fever, influenza, polio, right? You were quoting the kind of the vast differential between rates of infection and, and demographic size. So what kind of patterns are seen in terms of past epidemics?
That's a fascinating question, partly because they're not always reproduced in the same way as we've observed with COVID. And also partly because for historians, it can be quite difficult to, the data doesn't always exist that enable us to calculate mortality rates, for example, with any kind of confidence between different racial groups. A lot of it involves a bit of demographic estimation methods, for example. Were births registered? Were deaths registered? Is the census accurate for us to be able to calculate a mortality rate? And it's even harder with morbidity rates, because unless you know whether people were getting sick or not, it's very difficult to tell what the morbidity rates were. So it wasn't until, for example, that you got the introduction of disease registration and disease notification, one of the things that I'm interested in, towards the end of the 19th century, which was only for a subset of infectious diseases. It's only then that you can begin to understand the differential rates between certain groups, because you have diseases being reported. Now, that depends on whether people were actually going to see a doctor who would then report their disease. So there's a whole range of contingent things for me to say about whether we can do that. But there's a lot of interesting work that's going on with individual level data, and census, matching up death certificates to census data and so on, that shows that, I mean, certainly my own work on smallpox in Baltimore suggests that that there were big racial differentials in terms of smallpox mortality, but that was also partly connected to the accessibility and availability of vaccination within these different groups. So there's no single answer to that, but all the data I use in a class that I teach on the history of public health in Baltimore, a 1923 report by folks who, the Urban League, the Coloured Urban League of Baltimore, who produced a report called The Grim Reaper comes to Baltimore. In every single disease category they had, there was a huge racial differential between all the different kinds of diseases.
Yeah, I would bet that white settler colonies would be an interesting place to study that differential, right? And, because historians of Africa, for example, have long pointed out, because one of the so-called benefits of British colonialism was, well, we brought the railroads, we brought medicine. And then historians have taken that claim to task and said, well, medicine for whom, right? The disproportionate number of hospitals that were set up for, colonial personnel versus for the millions of natives. So I think that the empire provides, I think, a unique space to think about these racial differentials in terms of 19th century pandemics.
Yeah, and you may have brought transport networks, but you also brought diseases. So yeah, different kinds of diseases. So, and I think that links. I don't want to jump in, but there's a question there about the medicinal practice of colonized peoples. And I think, I mean, this isn't my area of expertise, but I do note it. One of the things I meant to mention but didn't was the way in which historians have begun to explore how colonial medicine became hybridized. The ways in which they expropriate, colonizers expropriated, some of the traditional, the indigenous medical practices, in order to make Western medical practice more familiar, more acceptable, and also sometimes recognizing that there was value in these different kinds of practices. So there's actually quite a fair bit of history of medicine work that demonstrates and shows how indigenous medical practices, therapies, drugs were meshed into imported colonial ones.
And this relates to another interesting question that popped up, which is, could you speak to the history of Black folks intentionally choosing medical autonomy and or preferring traditional or plant-based therapies, and whether or not you see that as a factor in vaccine resistance among that population?
I don't know as much about the answer to that, the last bit, but in terms of Black folks intentionally choosing medical autonomy, I think I think it's really important that we emphasize this. I know we thought we might get to it in the questions, but we didn't. So this is a really good chance to bring it up. The way in which, Black folks, indigenous folks, people of color have, I hesitate to say resisted white supremacy, but have provided their own alternatives to the sorts of and responses to exclusion and racism and oppression. So one example would be Booker T. Washington in the early 20th century set up the National Negro Health Week, which began in 1915, and this was and it expropriated some of the examples of white public health and white medicine, but it also incorporated ideas around Black health and how Black folks looked after their own kin. The Black Panther movement, the free medical clinics of the Black Panther movement in the 1960s are a really good example of the ways in which there was an active, there was an articulation of how medicine could be a way of a liberatory struggle there. The other good example is the term reproductive justice. That was a term that was coined by a caucus of Black feminists in the early to mid 1990s, and in some ways it's been expropriated by in other contexts and by other folks. But it was very much a way of Black feminists restating the sort of interconnectedness of health justice, social justice, other forms of justice that have to go together for reproductive justice and access to reproductive care, autonomy of the body, and making choices that are really significant, and that the white reproductive movement was ignoring or not sufficiently bringing it into the debates. So there are a bunch of ways in which, and I think what these things do for us as historians, they were both important at the time, but as historians, what they help us do is they help us recapture alternative narratives that white supremacist narratives routinely leave out, but they also stop us from the lazy sort of approach where to say something like, well, this is all in the past. It doesn't happen like that anymore. as if in the past there weren't alternative voices and there weren't alternatives to the white supremacist system, in the way that we can say now there are alternatives if we listen to black folks, if we listen to indigenous folks, if we listen to other people of colour, and we incorporate their views, their activities and their wants and needs into public health and medical provision.
So here's a question, and again, I'm happy to read these questions, but I also encourage anybody who wants to ask a question to just simply use the raise hand function at the bottom of your screen. So here's a question that says, you've spoken a lot about situations where medicine has failed us in the past, failed us, I believe, because of this structural racism, structural violence that you're talking about. Is there a country or a model that is out there in the world for us to look to with hope, a country that has eliminated structural racism or reduced structural violence and achieved sort of more health equity among, in its population? Is that a fair statement of your question, Alfonso? Perfect.
I don't know if we would say eliminates or, but I always point people to Cuba. Cuba is actually a really good example of where, it embarrasses a lot of other Western industrialized nations in terms of its healthcare outcomes. Now, you could argue that our healthcare, how do we measure health? The kinds of metric, and there's big debates amongst sociologists, anthropologists, global health folks about how we measure inequality using health metrics such as life expectancy, infant mortality, disability years lost, life years lost, and so on. And we're not thinking really about the quality of life rather than the length of life. But Cuba, if you go and look at all the data on Cuba, it's pretty, they do impressively well, and that is, commonly thought of to do with access to healthcare and so on, and where the sorts of inequalities are reduced by actually working on health equity and ensuring access for all. But I don't know enough about the long history of what happened in Cuba, or even right up to the very present. But I know that Cuba is always one that is always a case study that is helpful in that regard.
Doctor, if I could add, so I am a Cuban refugee. I came to when I was 10 years old, and I have been back to Cuba several times in recent years, and I'm afraid you have fallen to the message of the communist government of Cuba, which of course has no openness, no transparency, and doesn't ever reveal any information the way it really is. But put that aside, I mean, people in Cuba, the joke is, yes, the healthcare is free, but you can't afford the taxi to get to the hospital. Okay, yeah. I mean, it is a disastrous, it's an apartheid system. If you really want to talk about racial inequality, it's an apartheid system within a communist country, because if you have money or you're part of the government, you can use it. But if not, you're up the proverbial creek without a paddle. We work with Catholic Charity and go to Cuba with them all the time. And they do not have things like aspirin, Tylenol, all the basic stuff. So I think that's a terrible example, just my input.
Well, it's also one of the reasons why I said that focusing on quality of life and not just health metrics is important.
Well, I just think that's a terrible example, but thank you.
Well, what would you suggest is a better example?
I mean, I have children that live in Europe, and I think they are very happy with the German and the French system in terms of quality and affordability and the ability to get access for everybody, as opposed to, we do not have a national health system in this country. But I mean, I would just say that you should look a little more deeply into Cuba, because that's not a good example.
Well, maybe it's French and Germany if you look at it that closely.
Okay, maybe I can follow up with a question about, is there, we talked earlier about, the difference between your Lancet article being, published and sort of to great acclaim, and then versus the Journal of the American Medical Association denying structural racism. as a historian of the British Empire, it's hard for me to imagine that the British are less racist than the Americans. But I'm wondering, how does race function in terms of health equity in contemporary Britain versus sort of access to, you know, health equity in the contemporary United States? Do we see differences there?
It's a very pertinent question in the sense that there was recently a government report just last week about institutional racism in Britain, which dismissed it as a factor, pretty much dismissed it, said it doesn't have any kind of impact. Structural institutional racism doesn't have any impact on things like educational outcomes, health outcomes, and so on. So there's a misrepresentation of information and facts there. So there's that to point out, but there's also the point to say that, you know, medicine is quite often the end point of where people get to and why they get to. You know, going to the doctor or ending up in a hospital is very often, you know, an act of desperation and of last chance, because, you know, people for whatever reason, you know, they don't have the same kind or have equal access to healthcare. And there are ways in which it is manifested both structurally in terms of, you know, how people are referred for specialist treatments, which can differ not just by racial and ethnic group, but just by zip code or postcode. There's a lot of, you know, zip code allocation that's going on. And a lot of that, as I sort of referred to with the lung block issue, is associated with, you know, the kinds of groups who live in these places rather than just the places themselves. And, you know, so there's that, and then there's also very different kinds of levels of infrastructural spending within the health service by health code as well. It's not as, you know, the National Health Service is not as equitable as we would like to think it is. So there are ways in which that manifests itself as well. So there's that, and then on the individual level, individual physicians, all the studies show that that individual physicians have certain kinds of biases based upon, you know, perceptions around, you know, that are framed through class, race, and ethnicity. Some of them to do, for example, with pain. Some of them to do with the ability of certain groups to manage their own health and so on. So these things do come through, but there's, you know, something like the National Health Service mitigates some of the worst aspects or the most egregious aspects of the free market of healthcare that you have in a country like the US.
Excellent. Well, I see we're very conscious about time here. And it is 1:30. My colleague Rebecca Weiner just wanted to add to the conversation that, you know, there's also questions of bias along the lines of sexuality and gender. We don't have time to explore that humongous theme, Rebecca, but I did want to just take this moment to thank Professor Graham Mooney for joining us today and for kicking off what's going to be a series of 3 important and thought-provoking events about sort of the past and present history of pandemics. So I hope you'll join us next week, Wednesday, April 14th at 6 p.m. We have a roundtable discussion with 3 scholars from very different backgrounds who are going to talk to us about the past and present history of vaccinations. And then on Thursday, April 21st, we have our 3rd and final event of the month, and our 18th event of the year, the culminating event of our Decolonizing History series. We will have Sherelle Barber, who is a professor of epidemiology at Drexel, in conversation with Dr. Marcela Nunez-Smith, who is the co-chair of President Biden's Health Equity Task Force. So that will be a super interesting conversation. So I hope you all will stick with us. I hope to see you next week. I want to thank everybody who joined us, especially people who were brave enough to raise questions. We enjoy each and every one of them, and we look forward to seeing you again soon. Thank you so much, Professor Mooney.
Thank you. Thanks for having me, and thanks for all the questions. It was really interesting.
Okay. Good day, everybody.
Take care.